A lot of what you will do in pediatrics is reassure parents that nothing's wrong. I want you to put yourself in the mindset of a first-time parent. They have this thing that they've taken home with, that they have no idea how to handle, that they haven't really seen a lot of, and they have to take care of it all the time. Parents might end up paying too close attention, or that too close attention might fatigue and they may not pay close attention enough. And then something happens. What do? That's what this lecture is about, ALTE, BRUE, and SIDS. The question is going to be, can you simply reassure the parents that nothing is wrong, no big deal? Which takes courage to say, because just because you didn't find something doesn't mean it's not there. Or is this thing something you have to investigate? Now, kids have been surviving, barring infectious disease and catastrophic genetics, for a long time. And they didn't have modern medicine, and yet they continued to live. So most of the time, it is going to be reassurance, no big deal. But you have to have the confidence to know what to look for to say, I need to pay attention to this. Or, you know what? No big deal. Let's talk about the old term ALTE, and then talk about the new term BRUE, compare it to SIDS. Apparent life-threatening events. Terrorizing name, right? It's, oh my God, it could be life-threatening. They're not, though. And so an ALTE was defined by a concerned parent or caregiver. Somebody freaks out because there has been a change in the color, tone, or breathing of an infant. Something went wrong. One of these things changed. And color could be anything: pallor, red, cyanosis. Tone could be completely limp or contracted. And breathing could be any variation in the respiratory pattern. You can imagine that if that's the definition, there was a lot of investigation about whether or not this was a big deal. And since it's an apparent life-threatening event, you should probably pay attention. Talk more about that in just a little bit. The cool thing, though, was with ALTE, just like syncope, the answer is contained in the history. Very rarely do you need to go more than history, but every once in a while you could use the physical exam. Most of the time, it was just parents being freaked out. 50% of the time, nothing was found. But then the teaching used to go something like this. The most common causes after unexplained were going to be GERD, some lower airway infection, or seizure. And you can imagine if that's the teaching and someone comes in freaked out, my kid did something that's not normal, even though it probably was, a lot of stuff got done. Like kids were given medications or gotten x-rays, were evaluated for weird types of seizures. And then the stuff you really should be looking out for is going to be things like sepsis, heart disease, and abuse. The problem with this was that a parent came in freaked out, and then pediatricians ordered stuff. CBC, BMP, EKG, x-rays, pulse monitoring, pulse oximetry at home. And you ended up spending a lot of money and not finding anything. So what you want to be able to do is use the history to figure out which one of these things it probably is. And the history and physical can help you a lot. A seizure is going to present with eye movements that are abnormal and limb jerking. Someone who's septic is probably going to be infected, and these kids usually have fevers. Or at least there's going to be a change in the temp. Remember, sepsis criteria still includes hypothermia as well. Cardiovascular disease is going to present as failure to thrive. difficulty eating, or present with a murmur. Abuse has its own lecture, but in the very early period, what you're looking for are multiple injuries. Once a kid begins to walk or run, they bump into stuff. But infants rely on their parents to do everything, so if they've got a bunch of injuries, something was wrong. And so you can use the history and physical to narrow down some of the major diseases. And the emphasis was, don't go do testing. But when you read about ALTE or learned about it, no one had said that. So we got rid of ALTE. Instead came up with BRUE, which put a very specific diagnosis to the name. A brief, resolved, unexplained event. Now, in order to be a BRUE, the infant must be an infant, less than 1 year old. And it must be brief, less than 1 minute in duration. If it's something else other than that, you'd stop right there. And notice the similarities. It's a BRUE if you're less than 1 year old and 1 minute duration change in color, tone, breathing, or responsiveness. What the parent is worrying about is my kid dying? If it's a BRUE, the answer is no. But how do you know what to do as a provider? Well, this is why BRUE was created. Because if you have this, then you divide BRUEs into low risk and high risk. And here's what the American Academy of Family Physicians says. If you're high risk, you should probably do something. That is, monitor or investigate. But we're not going to give you specific recommendations on what you should do. You should use your history and physical to find out what thing it was and investigate that. There's not a workup for BRUE. There's only if it's high risk, then find out what it is and test for that thing. And high risk is anything that's not low risk. So what's low risk? Low risk BRUEs are going to be those things that do not have a history or a physical that is worrisome for any of these diseases. You don't have cyanosis, murmur, fever, evidence of abuse. You also want to make sure that these were brief and resolved, so there was no CPR that was required. It also has to be their first time, and they're not recurring within that same time, because that's probably something else. And then age has something to do with it too. Preemies always have it worse. If you were a term baby greater than 60 days old, makes you low risk. If you were a preemie, you need a gestational age greater than 32 weeks and a post-conception age greater than 45 weeks post-conception. If you are low risk, you do nothing. Don't evaluate, don't treat, don't give medications, don't get a pulse oximeter, don't get an apnea machine, don't buy cameras, 24/7 monitoring, don't do an EEG, don't do anything. Reassurance is the answer, if they're low risk. ALTE and BRUE are the same thing. BRUE has a better definition and it tells you what to do. It gives you an action item once you define low risk, high risk. And I'm talking a lot about these because this is the thing you reassure. You don't have to do anything. And it's all about cost-conscious care and not putting baby through unnecessary exposures or finding something that's abnormal and then having to act on it when really it was nothing to begin with. And if you never looked, it would never have mattered. But I'm going to draw a really big and thick line between ALTE BRUE and the last thing we're going to talk about, to really emphasize the point that there is absolutely no correlation whatsoever between an ALTE or a BRUE and sudden infant death syndrome. SIDS is its own disease on its own. But we talk about it here because when you name something a parent life-threatening event, everybody logically concludes, well, that, if I see that, then, oh, my kid's going to get SIDS. No. SIDS is defined as a child that dies for no reason. That is, based on the scene and autopsy, the infant is dead, and no one knows why. SIDS is a diagnosis you make after the autopsy is done, so not something you really want to diagnose. So chances are on your vignette, you're not going to have to diagnose SIDS. And as you deal with parents, you should probably try to prevent SIDS rather than make the diagnosis as the coroner. So the only thing I want you to learn about SIDS is prevention. What can you do to make baby lower risk? The number one thing is back to sleep. The Back to Sleep campaign has taught parents to lay the infant on their back. And if you think about this logically, the baby can't roll over on itself. And if you put it face down in fluffy pillows, and when you can't breathe, they can't tell anybody about it and they die. So chances are, if you put them face down, they get smothered. So put them on their back. The problem with putting someone on their back all the time is that they flatten their occiput. Turns out baby's going to just lay there the way you put them, so if you just turn their head to the side one night and turn it the other way the next night, they don't get that. Number two, don't share a bed. Don't share a bed, period, is a recommendation, but what they're saying is don't share a bed with a giant adult. Now, this also makes sense to me, even though this is not what's in the literature. If a 200-pound snoring adult rolls over onto a 3-pound infant that can't move, the adult will not realize it's done that and smother baby. If you have a cat and you do that to it, as you're rolling onto it, it's going to meow, scratch, and run away from you. Infants can't do that. So, don't share a bed. And number three, smoking cessation. Smoking is bad for everybody all the time. Stop doing it. What you don't do for SIDS is try to figure out who's going to get it. You don't do an EKG. You don't do pulse oximetry. You don't do apnea monitors. You don't do anything in the way of investigations. Premature infants have it worse. They're at higher risk. Kids with congenital defects are higher risk. But you know that because they already have disease. You don't have to do anything different. And of course, there's more to this in prevention, and if you read an article about it, there's 27 things you can do and 19 different risk factors. What I want you to learn is, put the kids on their back, don't share a bed with an adult, and the adult should stop smoking. That's how you're going to reduce the chance of SIDS. And, to re-emphasize the point, ALTE BRUE is one thing, and it exists on its own, completely unrelated to SIDS. That's ALTE BRUE SIDS.